Our next talk is on antibiotic decision, clinical or lab. The speaker doesn't need any introduction. He is a great teacher, practicing pediatrician for 55 years, former professor of pediatrics, Grant Medical College, former director of BJ Wadia Hospital for Children, former president and Indian Academy of Pediatrics. He has authored several books. Antibiotics are like a double-edged sword. The problem of antibiotic resistance is increasing globally due to indiscriminate and irrational use of antibiotics. To steer us in right direction, please welcome Dr. Y K Amdekar, sir.
Good morning, friends, and thank you very much, the organizers. Thank you very much, the organizers, for giving me this opportunity. I'm going to do an interactive session, and that's why I thought I should be right with you, simply because we all learn from each other. And I'm not professing to teach anything at all, but just sensitizing us to start thinking. And once we start thinking, we do a lot more within the knowledge that we have. We don't use the knowledge that we have. Why should we go for an advancing knowledge? We have enough to do well for 90-95% of the patients. Let me start. The antibiotics have been a big problem all over the world. We are not the only ones who misuse it. The whole world misuses. The whole world does not agree they misuse. We agree to it. That's the only difference. And to that extent, we need to be sure how we could be more rational within a simple, all things that we have, and that is history taking and clinical examination. Even without the investigation, we can be rational, and investigation may not add up much. And that's the whole process that I'm going to discuss. The next slide, please. Next slide, please. Can I have the remote so that I can change the slide? Fine. This is next. Now, acute onset of fever. You all see difficult problems because you see patients on the day one, maybe hour one. And I'm sure nothing can be known at that time. But the patient wants to know what the problem is. And therefore, my first question, we will just warm up ourselves. Raise your finger, I'll get the mic to you. Acute onset of fever. We must start an antibiotic. You might miss something serious. After a day, the child may have a convulsion and have meningitis. And then it would have been better if you had started an antibiotic on the day one. Don't you think so? No? So you're going to wait and watch. Okay? And therefore, can we suspect acute bacterial infection in first 2 days?
Yes.
And how do you suspect that?
The fever, clinical examination, and the
At that time, there is nothing positive.
may go up more on the second or third day.
Fine. I think
Patient may look toxic and all.
it's rare to diagnose acute bacterial infection in first 2 days. Unless the organism straight away gets into an area which you can see, like possibly a tonsillitis. Okay. But not easy otherwise. It takes a day or two for the organism to settle and start causing you trouble. And therefore, majority of the times you need to wait. Of course, you will examine carefully, but mostly it will be negative. We are talking about a very early course on day one. Okay. And therefore, mostly you will wait on that. So we are going to wait and watch, right? Now, I remember when I was at Wadia Hospital, every patient would be admitted for observation. And nobody said who will observe, what will we observe, how often will we observe. They left it to nature and the mother. So I said, don't write admit for observation, write who will observe, what observe, etc. So is it safe to wait and watch?
The red flag signs.
Excellent. You all know so well. Okay. Red flag sign, and therefore you will have to tell the parents or tell the patient, today there is nothing seen, and therefore just keep a watch on the red flags, and if they are all fine, don't worry, you will be all right. I'm sure we all are doing that. Now, we have already said how long to wait. I think the most important part is, if there are any other symptoms, are there generalized or localized symptoms? And what I'm trying to say is that a bacterial infection almost always have a localizing system. Pneumonia does not have a throat congestion. A streptococcal tonsillitis, pharyngitis does not have any chest signs. And therefore, if it is a viral infection, right from nose to down to bronchi, everything is involved. And therefore, generalized versus localized can make us decide whether we want to consider an antibiotic at all. And I think if no symptoms other than fever, I waited for 2-3 days. Okay, is it fine to start an empirical antibiotic? No, we are not still starting. Excellent.
Because we have viral fevers lasting for 6 to 7 days and child is very active in between the fevers.
Good, so good. And therefore, I'm sure so much enlightened people. Okay. The point is that we are enlightened, but we are often not confident to use our enlightenment. And we feel little upset and we say now 3-4 days enough. Even the patient is upset and we said it is much better to get on that. But yes. And then the problem is, if you decide to give an antibiotic, you don't know which antibiotic anyway.
Certain onset of fever. They have typical onset of fever, like viral fevers. They are very high onset. One may not get catarrh in first few days. And other family members, one has to concentrate that also. If we are not getting any clue, if the other members are also sick with viral fever, then second is, when we are practicing in a local area, we almost certainly see other patients coming with similar symptoms. So we have section of epidemiology for that phase of fever, And then intercurrent. If patient has fever, but moment the patient is afebrile and starts dancing and eating, we are very confident that we can wait. Thank you.
Can we join me so that if I can't understand something, at least you can say that. No, excellent. I think give him a clap. What a complete answer. And I saw he was answering the question in the previous thing, spine also. Okay, wonderful. You're an all-rounder, sir. Okay, thank you very much. And I think let's get to the next thing. Now, antibiotic use, are laboratory useful? Now, you won't speak for the first time. You will speak after I finish. Okay, yeah. Do you think CBC, ASR, CRP, SGPT, I don't know, fever panel is expanding. Anything useful in the first 2-3 days? No. And therefore, we will not do any test in the first 2-3 days. Anyway, we won't know anything about it. How often do you see a pathogen? We have a bacterial infections in our community. We use antibiotic. We use our brain. How often do you use cultures and all that? Or we have no such culture in this country? Fine. And therefore, the whole world says evidence-based. Now, you jump from the top floor, you don't have to have an evidence, you will break all the bones. So we here go by what is most likely to be right, and we keep a watch whether we are going wrong, and if only suspected to be going wrong, we will investigate, but we will not rush in to do any investigation straight off. Why not be safe and use a broad spectrum antibiotics? Today we have broadest spectrum. Everybody gets killed. Maybe a patient also. So,
Resistance without when it is not indicated also.
and therefore, that's not a way to go by at all. And therefore, can antibiotic resistance develop without the presence of infection? See, I have a viral infection. Okay, I have no bacteria in my throat or in my skin or my GI. And then I give an antibiotic. What is wrong? There is no bacteria there to get resistance. Correct? So is it safe? Why? I have no bacterium, no? How will it get antibiotic resistance?
Everywhere there are commensals. So everywhere there are commensals. So bacteria there, throat, eyes, skin, everywhere. We are covered.
Excellent. And therefore, there are commensals sitting to get resistant, but even otherwise, you may have had an antibiotic resistant germ that you have passed on to me, and therefore I have never had an antibiotic, but you gave me a germ with an antibiotic resistance already. And that's all in the community. So even without an infection and without taking an antibiotic, I am already having an antibiotic resistant germ. Imagine how difficult it is, right? And therefore, now we start votings. Okay? Voting only because that many of us feel a little awkward to be wrong. But it is said that if you are wrong, you will never forget that again. If you do not come out, then you will never improve. But all the same, I thought e-voting is a good idea about that. Now, this was an 8-year-old, healthy, asymptomatic child, woke up in the morning with high fever, 104, paracetamol given, no benefit, started talking irrelevantly, and developed a few red spots on the skin. All happened in within. These are all real cases that we have seen. Nothing is virtual. And the parents brought this child at 8 in the morning. He said, from 4 o'clock, we are trying to control fever, but now he's talking irrelevantly and has some skin spots. And now your options are, I will give IM paracetamol, fever is very high. In addition, I'll do CBC, CRP, urine. I will add amoxiclav or straight away hospitalize. Your voting starts now. Majority of you want to send him to the hospital. Would somebody raise the finger and say, why hospitalize?
Because I'm suspecting meningococcal meningitis because the red spots.
I will stop my presentation here. You know all that.
With high fever, this patient may be having mild alteration. What we say, I forgot that word. He's not altered sensorium, he's talking basically. So once we bring down the temperature, wait and see the patient. Maybe the fever itself is causing some problem. And red spot, we have not mentioned what kind of red spots they are there. If they are absolutely hemorrhagic spots, then definitely I'll think about meningococci. Otherwise, viral also gives rashes. But day one, rashes are very uncommon. So meningococcal comes top on the list. Thank you.
I think what this case tells us that a behavior abnormality is a serious problem indicating that the brain is already getting involved. What is going to happen, whether it's going to be in sepsis, in shock, in meningitis, the time will decide, but a behavior change. And I think a sudden behavior change is certainly something very, very serious. And I think that's what it is. And the right answer, meningococcal meningitis. Imagine, we in India don't need cultures. We have a brain. So wonderful. It was a meningococcal meningitis. And therefore, the best treatment would have been penicillin. And if you started penicillin, this is one time of infection where penicillin works wonders. Of course, must be working wonders in similar penicillin-sensitive organisms, but this is where you can save this person. In the next 12 hours, if this was not diagnosed, he could almost come fatally. So how important it is to just pick up a behavior change. And what small behavior change? Just an irrelevant talking. Somebody may be little lethargic, somebody may be little irritable, unduly lethargic, unduly irritable. That's a behavior change. Excellent. I think we have started in a very, very correct way. Let's see another one. This child presented with high fever, severe intolerable body ache and headache for 2 days. Make a note, severe intolerable body ache and headache for 2 days. Day 3 developed a rash over palms and soles, pink, non-blanching, Look sick, fever continued, no other signs. Now your options are paracetamol and observe, in addition to some tests. Above tests also start IV ceftriaxone or do none of the above. Your time starts now. Fine. Few people want to observe. Who wants to say why observe? Observe, yes, but you don't want to observe him deteriorating. Okay, observe means it's safe to observe. So who would say why? Doesn't matter. Okay.
It sounds like dengue fever, break bone fever probably, so we will have to observe.
What?
Because it can go into dengue hemorrhagic fever or dengue septic shocks.
So what they're trying to say is that when examination is normal, all they want to say is that there is nothing serious impending right today. Okay, tomorrow evolves something we don't know. And therefore, why rush in, but tell the patient to look at all probabilities, and therefore wait and watch may be not a bad idea. Okay, but who wants to do all those tests? No. They can pick up early. See, when I was trained and some of you were trained 60 years ago, ESR was the only one. Then came CRP. And they said ESR takes time. CRP comes early. By the time I learned what is CRP, procalcitonin came in. And they said it comes within 2 hours, 4 hours. Now I am waiting for some bug which has come to my neighbor, but my test becomes positive. They say he's across your... Yeah. So the question is, when you do not know what you are looking for, in short, the tests are not to search for the diagnosis, tests are to confirm or rule out a provisional diagnosis made clinically. And therefore, none of the above may be a reasonable answer, but the first wait and watch with paracetamol. See, we do not know what next is happening, but that day, observation is a good idea, okay? And if you don't want to observe, then you are doing something irrational. The test results may take another 12 hours, 24 hours. Mostly they will not tell you what it is. If you give an IV ceftriaxone, you will not know whether a ceftriaxone was the right one, but is going to modify the course of the illness. So you will be further in trouble. And just to make a point, therefore, back to the slide. Yeah, suggested vasculitis in a sick child. What I wanted to tell you is that this is one area where you will use not the usual antibiotics. This is possibly a rickettsia, and therefore we use doxycycline. I recall many times there was a fever which was foxing. Late Dr. Ramamurthy was very in favor of using doxycycline. I was wondering why it is. Most of us in pediatrics don't like to use doxycycline, especially in an earlier age. And I used to ask Dr. Ramamurthy, why is your choice? He said, when they have tried the common antibiotics, I know something else needs to be given. And he had possibly one of such, not uncommon today. Of course, in the city, we may not be seeing it, but go little periphery, you will see all this. This was just to tell you that a sick vasculitic, but even then, observe carefully was not a bad idea at that stage. Let's see, 4-year-old presented with high fever, cold for 2 days, and excessive crying for a day. Okay. Now this also tells you how important it is to ask all the details. This is not just fever, cold, excessive crying. And a 4-year-old. Physical examination is NAD, and your options are symptomatic treatment, CBC, amoxiclav, cefixime. Your time starts now. Well, most of you want to give symptomatic treatment. I know occasionally one of my patients would send some neighbor, and he is the person who wants a quick cure and he wants a quick action. Do tests, give some 2-3 drugs, and when I don't know that, he would say, no, he is too conservative. He possibly doesn't know what advances have occurred. He just says, wait and watch. Okay. Now the question is, why do you want to wait here? He's excessively crying. You can just wait and tell the mother, let him cry, let's all wait. He will not stop crying. He will not stop. Examination NAD. You know what is NAD? Not actually done. Okay. And the reason is, this is really true in this child, because he has a cold. And a child who is crying with cold has likely to be an earache. And how many of us do an otoscopy? Okay.
I do otoscopy.
Yes, excellent. Excellent. And I think unless you start peeping into the ear, you won't know how to diagnose early otitis media.
Yeah.
So happy. Okay. Yeah.
So the patient may be physically normal, okay. Just see the surrounding on which the patient is lying. There can be an ant, there can be bite from some insect, which is irritating, because we found one patient was bitten with a rat and he was crying, nobody was understanding, and then the patient came backside, we saw that.
I'm sure when a child comes crying, we also don't know why he's crying. Mother feels you must know, but I feel mother must know. Okay, so normally what I do, I put my hand on the tummy and say, looks like a colic, I'll give you an antispasmodic. Okay, so I think this is the one. The question is, somebody therefore have said that, now most of you want to wait and watch, right? Symptomatic. Don't you think this drum will burst, pus will flow? And I remember a 4-year-old child is different. Okay, but a child came with such a story and he said, no, my doctor said wait and watch, and really, sir, pain disappeared, but only pus is flowing. Now I know that pus flows to start off the pain, and the parents would thank me to say, sir, wonderful. Crying stopped, pain stopped. And then I learn, oh, I've done some harm. So don't you think it's a harm to wait?
CBC has been done, we would have ruled out an acute bacterial infection.
And therefore, the message that I wanted to give you is that day 4 the symptoms persist, eardrum got congested, now somebody like you put in an otoscope then, and fine. Now are you ready to give an... Yes. All right. And therefore, this is what is now accepted all over the world. In United States, about a decade ago or a little more, people started using on such patients an antibiotic, and they started getting a resistant strains.
So even with plain simple eustachian tube dysfunction, ENT people, they give antibiotics saying that the fluid builds up, can get infected.
Excellent. There could be many reasons besides the bacterial infection, and even a viral infection will do the same. Okay. And because in US, people like all of us there also, they started using antibiotics, simple infection started getting resistant strains, and then the problem came up, antibiotics were not working. So the recommendations came, and today the IAP also has the same recommendation, that if age is less than 6 months, okay, then start an antibiotic straight off. We are talking about a suspected otitis before the drum bursts. If it's a little older child, okay, up to 2 years, and the symptoms are very severe, you may also start an antibiotic, but beyond 2 years, wait and watch, and what he said rightly, this child would just get better with paracetamol and nothing else, and then you see how to prevent the recurrences. That's another story. So take a note of that. This is now a strong recommendation to use antibiotics rationally, even if you are suspecting. Now what happens if you wait for day 4 and the fever persists, pain persists? then you must start antibiotic, and it has been adequately proved that that kind of a duration which you waited is not going to harm the child at that age. But had it been a 2-year-old or a 1-year-old, it could have vastly grown further and caused the damage to the thing. So this is another recommendation, and I think that is how the whole thing goes on. Let's look at next one. 8-year-old, high fever, dry cough, and pain while swallowing for 2 days. Okay? On examination, showed a sick child with congested throat and a macular skin rash all over the body. Now your options are symptomatic treatment, in addition CBC, in addition throat swab, or give amoxicillin. Your time starts now. Well, we are democratic country, so reasonably, okay, good. So, who would say that they would wait and watch? Doesn't matter, okay, because any one of us could be right. Once we were doing an interactive program, only one person gave a right answer. And I said, who is this? Nobody raised the finger. I said, he's the only one. He said, yes, I am the one.
So here the patient is coughing. He has a dry cough, high fever, dry cough, pain while swallowing. So I would suspect a viral illness, because had it been tonsillitis, tonsillitis will not present with cough. That's why I want to be.
All right. So she is going to wait with a viral infection, maybe. Fine. Okay. You have any comments on that? You have always been. When I don't know what to say, I come back to you.
I have replied all your past cases as wrong. My voting was very wrong. So I cannot, but here very striking is the child is sick actually. And there is dysphagia. And with that there is macular rash also. We have to think very, this is a serious child basically.
Well, I think he earlier said while discussing that a typical viral infection, when the fever comes down, he looks much better. And he's trying to tell us that if he's looking sick, then possibly it's a bacterial infection. Okay. Waiting for a while may not have harmed in such situation, but the point is again, the rash does not mean a viral infection necessarily. Even a streptococcal infection will have a rash, and many other bacterial infections also have a rash. So sickness might prompt you to consider this as a bacterial infection, and therefore you might have considered this to be a thing. Let's get to the next pain. A 4-year-old present with...
Sir, in the previous case, if the child had not been given measles, this dry cough and high fever, would it not go in favor of prodromal symptoms of measles also?
If the child is having measles, to start with fever, with running nose, and other things will come. So,
And I think in that previous child, I had put down dry cough. Okay, wet cough is all over the lower airways, and therefore possibly not one of those. Let's look at...
What would be the answer?
And what is the answer for the last case?
See, the point is, a sickness, even if the fever comes down, points strongly that you are likely to be bacterial infection. Not every time. After all, what sickness? It's very, very important, especially in pediatric patients, because the pediatric patients are innocent. Okay. They are not adults. And what's the difference between pediatric patients and adult patients? The pediatric patients are not adulterated. And I suppose so also pediatricians. I'm sure I have one support there. Okay. So the point is, you may be wrong. I'm not saying. See, 120 years ago, William Osler said, medicine is a science of uncertainty and an art of probability. We are using art of probability. And this is true even with lot of advances. That art of probability is the way to go by, and of course watch if you are going to be wrong, right? Let's look at,
The answer was D, right? Yes.
fine, fine. A 4-year-old presents with mild fever and dry cough. Fever settled down in next 2 days, but the cough worsened progressively. Family history of similar cough in 2 other members. Your options are symptomatic treatment, CBC, amoxiclav, or none of the above. Your time starts now. Now, why do you want to wait?
Here you are having a family history of similar cough in 2 others. Normally the viral will start with cold fever and then later on it progresses for a while and then gradually settles. So we'll observe the child but symptomatic therapy.
So most of you thought this must be viral because he did say that family members, epidemiology.
This is hyperreactive airway, which usually happens in few individuals after viral infections.
And therefore, the point is, I said dry cough. Hyperreactive airway, viral infections, all are a wet cough. This is not a lower airway disorder. This is an upper airway. But upper airway where the fever has quickly disappeared. Upper airway is a localized symptom. And we said localized symptom more likely bacterial. But the fever has disappeared. So it's a bacterial infection where the fever may not be a prominent symptom and 2 other members. So this is a pertussis starting. Whooping cough. And obviously the none of the above is the right answer because we don't need amoxiclav there. Okay. And therefore, look at how important is that. We all learned this in the first clinical term. Dry cough versus wet cough. But thereafter, we were so quick, going in a fast mode, we said cough is cough, forget what it is. So much of important, okay? And therefore, this was really a pertussis, and to that extent, a macrolide is the answer, and that is how it is. Let's look at the... Now, there was no change. You use azithromycin, and the patient says, useless, antibiotic has not done anything. Now, would you upgrade the antibiotic? Would you ask for more tests?
I'll not upgrade because we have to give time. It may take 1 to 3 weeks also for the cough to settle.
And when the pertussis starts and you are never there in the first 2-3 days to diagnose, the cough will take its own sweet time, 2 weeks, 3 weeks, and that will not change with antibiotic at all. And therefore, you need to counsel the parents that the cough will take its own time. Then the question is, why do you give an antibiotic? My problem is cough. And you say after antibiotic the cough persists. Then are you not misusing an antibiotic?
So in the first 5 days, if you are going to give, you are preventing the complications which pertussis is going to cause.
And therefore, it will not spread further, so at least you must give an antibiotic. Okay? So that assure the parent. 10-year-old presented with moderate fever and severe cough for last 3 days. Take a note of every small little thing. Physical examination, not sick looking. Mild tachypnea. Signs of consolidation on the right lower chest anteriorly, plus bilateral crepitations. Chest X-ray confirmed pneumonia with generalized bronchovascular markings. Your options are amoxiclav, macrolide, cefixime, or hospitalize and give IV ceftriaxone. Your time starts now. Why hospitalized? See, not sick looking, mild tachypnea. Okay. Okay. So because it is a pneumonia, you want to hospitalize? No need. You want to give one of those antibiotics. So most of them have said amoxiclav or hospitalize. What is the possible etiology of this?
Atypical viral pneumonia.
Viral, okay. Now look at that. Severe cough last 3 days. Viral pneumonias are known. But again, we will go by what he said, other family members, epidemiology, community, etc. The point I'm making is that this is a kind of pneumonia where a person is not sick and still has a pneumonia, and it's also bacterial, and these are intercellular organisms like mycoplasma, and they need a macrolide, and they are not serious. And what's the difference? A pneumonia is a localized disease, but this child has got a bilateral crepitations. That means he has an airway involved and also lung parenchyma involved. It becomes generalized. That's why you thought viral, yes, but then epidemiology. And therefore, a type of bacterial infection, intracellular, can almost mimic viral, but viral typically would have a running nose. Okay. So therefore, this child would have a mycoplasma pneumonia and possibly asking for. Let's get to that. 10-year-old presented with high fever and headache for 2 days and 1 vomit. Fever and headache transiently better with paracetamol, no other symptoms. Physical examination normal. Your options are paracetamol and observe. Addition, you do CBC and even consider CSF. In addition, order CT scan of the brain and straight away hospitalize and give ceftriaxone. Your time starts now. Most of you say, observe, great guts, fever, headache, vomiting, but I congratulate you. Who said wait and watch? Many of you have said. So convince us why wait and watch. Fever, headache, vomiting. I learned my first clinical term, oh, it's meningitis. So would you still wait?
So there's only one episode of vomiting and transient headache.
Very good. The point is, you look at that fever and headache transiently better after paracetamol. It rules out meningitis. Okay, and it's a simple viral infection. Do nothing. Okay, but yeah, this is just to tell you that fever, headache, vomiting is, yeah, but what is the, yeah, next stiffness may come a little later. Okay, but the point is, what is the sequence? Fever first, after 2 days headache and vomiting, because fever is the first symptom of bacteremia, and then the bacteria have to go to the brain, meninges, and it takes 24 hours, 48 hours. So the sequence is fever for first 2 days, headache, vomiting thereafter, and does not get relieved even if the fever gets relieved. So this is a simple viral infection and do nothing at all, okay? 2-year-old presented with high fever, cold and cough for 2 days, no other symptoms. Physical examination was normal, but still somebody did a count. We all said don't be in a hurry to do CBC, etc. But some clever fellow did it. And he found count was high, urine was showing 8 to 10 pus cells. Now options are urine culture and wait for results, urine culture and start amoxiclav, or urine culture and start cefixime, or even hospitalized. You have a 2-year-old child. Okay. What do? Your time starts now. Do you have 5 minutes? Yeah. Fine. This is just to tell you that first, would you have done this test? You have a fever and cold. But he found something. So is it that our philosophy doesn't work?
Increase in neutrophils count in viral fever as well. Initial neutrophil can go up.
Madam, there are 8 to 10 pus cells in urine. And now I will show you something more. Why is it? No, go back. Urine culture positive E. coli.
Significant. Sir, coli colony significant. E. coli colony.
Absolutely, more than 10 raised to 5.
We are practicing adult medicine, so white cell count in a 2-year child, how much it should be, we don't know, first of all. So whether this WBC count is significant or non-significant in a 2-year child, because pathologists, when they give reference of adult this thing. So we don't know about this, but 8 to 10 pus cells are significant. But whether they are causing fever or not, we are not sure about it.
Counts are nearly similar beyond 2-3 months of age, and therefore neonate, yes. Early infancy maybe, but thereafter the counts interpretation are same. The point is, it's still not a UTI, and take a note of this. First thing is that you all said you would not have done any test. So when you thought there was no need of a test, don't think the test will guide you. And this is what it is now known, that E. coli are sitting there, like in our throat strep is sitting there. And look at the symptom, fever and cold. Which UTI has a running nose? Okay. So first thing, you would not have done it. And if you did it, you should know not to depend on it. The problem is, they give a type report which looks black and white, but there is a lot of gray in that. And there, ignore if it's only E. coli, even if it's 10 raised to 5 and more. In a child who has no symptoms related to UTI, don't ignore it, but say, I'm not going to treat and I'll wait. And if the fever disappears in another day, you know it was not UTI. So this was just to show you how we go. 2-year-old presented with high fever for 2 days, no other symptoms. Physical examination NAD, malaria antigen positive. Malaria is one type of infection where you could do a blood test right away in the first hour also. Okay. And therefore, fever continued in spite of chloroquine, developed a skin rash 2 days later. And your options are stop chloroquine and observe. In addition, start artemether, complete chloroquine therapy with antihistamine, stop chloroquine and look for an alternative diagnosis. Your time starts now. Fine. To make it a little quick, we will say that the point is, this child, I wanted to show that antigen positive may not mean an active malaria. Antigen remains there for some days. And therefore, wait and watch and see what is the pattern of fever. If the pattern of fever every 6 hours, 4 hours, you need to give paracetamol, then that's unlikely a malaria. And this was just to show you that a positive test may not mean the right diagnosis. Okay? We will quickly go in the next 2 minutes. Is that all right, madam? Yes. Quickly, I want to show that see, polymorphs are high, platelets are normal, acute bacterial infection. Similar thing. Polymorphs are high count, platelets are high, and eosinophil is normal. What is that? The second one looks like the first one. High count, high neutrophils. Okay, the difference is the eosinophils are normal and the platelets are high. This is to show you that more than polys and lymphos, and more than the total count, of course they are important, but the other cells are equally important. And majority of an acute bacterial or acute viral infections, eosinophils go down to almost zero. And if eosinophils have not done that, it is likely to be non-infective, and therefore this is a systemic inflammatory disease. Now somebody was saying that even acute viral infection have a same thing, but you may be lucky after 2-3 days, lymphocytes may come up and the platelets may go down, but in the first 2 days, you will look like exactly bacterial, and therefore don't do the counts in the first 2-3 days. And the remaining thing is not difficult. I will just go through that. Typhoid is very typical. Low count. Look at that bacterial infection, but still low count and not polymorphs, lymphocytes, and you have zero eosinophils. Zero eosinophils is acute bacterial or viral, and platelets are low. So typically monocytosis, lymphocytosis, leukopenia, thrombocytopenia, you can almost bet in our epidemiology, send a blood culture, but you can start the treatment. It is that fine. I'll just end up with a take-home message. Generally, no infection deteriorates within 2 days, and hence wait and watch is a good idea. Watch for a change in behavior, skin rash, tonsillar membrane. We don't see diphtheria much, but periphery diphtheria is still there. And then generalized versus localized symptoms. And if you have a bacterial infection above diaphragm, give a gram positive. If it's below diaphragm, give gram negative. Confirm etiology in typhoid, UTI, TB, malaria, meningitis. Viral, possibly not. Today we have a biofire, and we get fired by doing all such things. You get not one but multiple organisms. And therefore, high fever beyond day 3, day 4, or low-grade fever with systemic symptoms, now investigate even before starting an antibiotic, right? I will just... Dr. Tushar Manear has been one of my team members, and we have started a YouTube channel. It does not teach medicine, it teaches how to sensitize thinking. And we call it STEER, which is sensitizing to think, enabling excellence and rationality. If we think, we are rational and we do the best to the patient. And thinking doesn't take time. Once you practice, thinking becomes easy, and therefore you can just go on the YouTube and say STEER by Dr. Amdekar's team, and you will find we have already done about 8 videos. We upload every Tuesday and Friday at 7 in the morning a new 10-minute video. It's just a 10-minute to sensitize you that you start thinking and you will know it. I have 7-8 members in my team, and we all are going to participate, and I hope to continue it for a very, very long time. And those who are very technological savvy, okay, this is your QR code, and I hope that you will enjoy it. It's free, it's without advertisements in between, and I'm sure that you will possibly enjoy doing it. It's a 10-minute one. Even while coming in between, okay, you can have a look. Thank you very much for this opportunity.
Thank you, sir, for the excellent talk. I request GPA President Dr. Preeti Bhargava to felicitate Dr. Amdekar, sir.